So I want to thank everybody who's come today to hear about this important topic. We have some great experts in the field to help clarify and enlighten us on some of the mental health issues here in Fairfield County and beyond, some of the interventions that are being made, and some of the great needs and how, you know, corporate funders can support this great need in our county. We are very fortunate to have some very talented people. We have Terry Wood as our moderator, and then we have three panelists. Judith Myers, who will be joining us shortly, Nancy Von Mueller, and Sherry Pearlstein. And I'm just going to give you, their background is fabulous and it's long, but for purposes of this panel, I'm just going to give you a little slice of background on each of them, just to give you a little perspective, in case you don't know who they all are. Terry Wood is State Representative for Darien and Norwalk. She currently is serving her third term, following 20 years of community service, advocacy, and leadership. She is co-chair of the Mental Health Working Group of the Gun Violence and School Security Bill in response to the Sandy Hook School Massacre, and was instrumental in crafting and implementing the mental health portion of the bill. Ms. Wood also is ranking member of the Human Services Committee and member of the Appropriations and Regulations Review Committees. In addition, she is co-chair of the Moore Special Education Committee. To my left, Sherry Pearlstein is a clinical social worker with over 30 years of experience as a mental health clinician, a supervisor, and a senior executive. She is the president and CEO of Child Guidance Center of Southern Connecticut, an outpatient mental health agency for children, adolescents, and their families. Ms. Pearlstein served on the Connecticut Governor's Blue Ribbon Commission on Mental Health. She was appointed in 2006 and again in 2013 to serve on the state legislator's Behavioral Health Partnership Oversight Council. Prior to assuming leadership of the Child Guidance Center, Ms. Pearlstein was Director of Mental Health Services for New York City's Victim Services Agency. She is past chairperson of the Children's Division of the Connecticut Community Providers Association and past executive committee member of the Board of Directors. To her left is Nancy Von Mueller, who is one of my colleagues at the Fairfield County Community Foundation. Nancy is a program director who oversees grant making and community leadership for the Fairfield County Community Foundation's Economic Opportunity and Health and Human Services priority areas. She brings more than 20 years of experience in program development, grant making, and grants management in the public and nonprofit sectors. Ms. Von Mueller also serves as the staff liaison to the Bridgeport Public Housing Resident Support Fund at FCCF, which benefits residents of Bridgeport Public Housing, and manages the PT Partners Initiative, a collaborative, resident-driven initiative aimed at developing and demonstrating a sustainable and replicable process for community transformation within public housing neighborhoods. And our third panelist.
Why don't you introduce Judith when she gets here?
Yeah. Should I do that?
Yeah.
Okay, that's fine. Our third panelist will be with us shortly, and I will introduce her when she comes from her treacherous commute from North Haven, Connecticut on 95. So without further ado, I would like to welcome all of our panelists. Thank you for being here. I'm going to turn it over to Terry to take us through this discussion. Thank you.
Great, thank you, Carol. Yeah, thank you, Carol, and thank you certainly to Fairfield County Community Foundation and Purdue Pharma for hosting this. Nancy, why is this important, mental health?
So I was asked to talk a little bit about why corporate funders should care, and I thought that I would start by just sharing some of the statistics and stories, because I think they sort of tell you why you should care. Just in general, 18.6% of Connecticut adults experienced some form of mental illness in the past year, so basically 1 out of 5. Suicide is the 10th leading cause of death in our nation, and the 2nd leading cause of death for people ages 10 to 34. Most people will be surprised to learn that more people die by suicide in our country than in car accidents. And I think people will also be surprised that suicide deaths account for the majority of deaths by firearms in our country. Many of you probably don't have mental health or mental illness as priority areas for your corporate funding. But I wanted to relate statistics that show you that regardless of what you're focusing on, your funding is focused on, mental health is critical to the needs that you're trying to address. If you care about early childhood and education, early identification and treatment of behavioral health issues is essential to educational success. The state of Connecticut, in informing their behavioral health plan, had a forum that they hosted. They're hosting 5 all over the state, but they hosted the most recent and last, I believe, was hosted in Stamford this past Tuesday evening. And a parent of twins testified that one of her twin sons suffers from a mental illness. She first recognized those symptoms of mental illness when he was just 3 years old. It took 4 years for her to get a diagnosis for her son. And her son is exactly 4 years behind his twin in school. So, a very tangible evidence of the role of early identification and treatment. If you care about youth and young adults, 8.3% of 12 to 17-year-olds and of 18 to 25-year-olds had a major depressive episode in the past year. 7.9% of young adults 18 to 25 and 3.2% of all adults 18 or older have a serious mental illness. 14.6% of high school students seriously considered suicide in the past year, and 6.7% made at least one attempt. The number of calls to the under 18 crisis line covering Southern Connecticut jumped 58% between July and December 2013 as compared to the prior year. If you care about the justice system, 70% of youth in the juvenile justice system meet the criteria for at least one mental health disorder, such as major depression, bipolar disorder, or anxiety conditions. 64.2% of adult inmates who have a mental disorder, 64.2% of adult inmates have a mental disorder, but fewer than half of them receive treatment for that disorder. If you care about homelessness and housing, mental illness and substance abuse are 2 of the most commonly cited reasons for homelessness. 39% of homeless individuals report some form of mental illness, and 20 to 25% meet the criteria for serious mental illness. If you care about senior citizens, 1 in 4 senior citizens suffer from some sort of mental health issue, the most common being dementia, depression, and anxiety. And access to community-based treatment for these disorders can be the determining factor in whether or not a senior can age in place. And if you care about health and wellness, in part because of access to care issues, individuals with mental illness and or substance abuse are amongst the highest users of expensive emergency department care at a significant cost to our healthcare system. So I think that sort of tells the story about why, regardless of what your philanthropy is focused on, you cannot ignore mental health as an issue.
Can I add something to that? I first of all, thank you so much, because the numbers really speak. We struggle often to convince funders that there's a connection between mental health and school performance. And those companies that are interested in supporting school success say, no, we mean, things that we can see a direct correlation between. And it always confuses me, because it's so apparent that if a kid is depressed, if a kid is acting out, if a kid has behavior problems, they are not going to learn. And others in that classroom, when a kid's acting out, are also not going to learn, because the teacher's going to be absorbed by the behavior that's going on. And then the school system is going to start excluding, is pushed to exclude kids who are disruptive. And then you have the costs associated with all of that. And I want to say something positive, because I don't often get a chance to do this, but because you've painted the picture of how prevalent the problem is, we are so much better at dealing with the problem when we get kids in a timely way. We have much more effective treatments. I've been in the field a long time, and I think when Judith gets here, she'll talk about some of the advances because her institute has done a lot of the research. We're much better at treating than we used to be. But the longer a kid waits to get help, the harder the problem is, the more difficult it is to engage them and their families. People are frustrated, and it's going to take longer to get the kind of results you want. If we have the resources and we can get in there quickly, and there are some exciting new interventions, we do so much better. And so, you know, there's this stuff about, well, can it wait, and what's the priority, and it can't wait. The life, you know, what happens in those first 5 years is crucial. We now have ways to identify those kids real young. We have great interventions, but we need to be able to have the resources to get in there and get in
Employ
there.
them, yeah.
Yeah, I think that's so true and so well said. I think one of the frustrating parts on the legislative side is so often people want to see evidence, and you want to be able to quantify it. And I think how far we've come in some physical illnesses, cancer being one of them. 25 years ago, 30 years ago, we wouldn't talk about cancer. If you had it, you hid it. And the research wasn't there. Well, now the research is there, and now mental illness, I think, is one of the last frontiers that we absolutely need to put our commitment, our time, and energy behind, particularly early intervention. And this, I would love a copy of what you read, because that is spot on. People are astounded when they find out more people die every year from suicide than almost anything else. 36,000 people a year, and the majority of those use guns. And that is the largest death. How do I say that? More people die from suicide with a gun than die by homicide by a gun. And people are astounded to hear that.
And for kids, if you look at the statistics of cancer, heart disease, stroke, emphysema, you know, the whole list, all of the AIDS, all of those combined, more kids die of suicide than all the physical health illnesses combined.
And I think what's really interesting too, and I have a chart that I could share with people afterwards, but if you look at NIH support of research across diseases like heart disease,
Right.
cancer, pulmonary disease, and suicide, there's and HIV/AIDS also, there's a direct correlation to the reduction in incidence of those diseases and spending. So you will see HIV/AIDS up here with the most spending and the most dramatic reduction in incidence of deaths, and suicide down here with the least amount of spending on research and the least decrease in incidence. Actually, the only one where there's been an increase in deaths.
And the numbers, these numbers, statistics have held over 35 plus years on suicide.
Yeah.
So I think that's important. Yeah, it's pretty stunning. I'm going to review some of the legislative things we did in conjunction with the school safety bill in response to Newtown last year was divided into 3 sections. The gun section, which looked at background checks and all kinds of things. And that was the most controversial and certainly, I think, had the most press on it. And I think some of the things we did were very, very good. Why Washington can't get this together is another subject. That's not why we're here. In the mental health part, we created a 20-member task force, and they have just finished meeting. And you can go to the website and look at the minutes, look at the meetings. Very thorough. I reviewed a number of the meetings and the minutes, and a terrific group of people. It's headed by Dr. Connor of UConn and Dr. Ryan of Yale. And Dr. Ryan of Yale is a pediatric psychiatrist. So they both have great experience in this area of mental illness, and they're looking specifically at ages 16 to 25. And I did ask, should they have looked a little younger at that delivery system? And what it's called is the Task Force to Study the Provision of Behavioral Health Services for Young Adults ages 16 to 25. I'm not going to go through all of it. It is on the website. I'm happy to cover it with anybody, but offline. They did cover, make 50 recommendations, and I believe they'll be paring that down. But to create the awareness that this is important and to help destigmatize mental illness, was our overriding goal. So those recommendations are going to be coming out very soon. And the couple other initiatives in the bill was to administer mental health first aid training program in consultation with State Department of Education. Mental health first aid is a nationally certified course. It's a 12-hour course. I've taken it twice. You only need to take it once, but I took it twice just to really absorb the information. And it's very similar to the basic Red Cross first aid course we all have taken when our kids were younger, or when we were younger. And it teaches people what mental illness looks like. It can be very simple anxiety in a 5-year-old, which, as Sherry points out, without it being diagnosed. Legislative side, the mental health first aid course, I've organized 3 of them in Darien. It's usually done in 2 days, 9 to 3, with a lunch break. And it's wonderful information on identifying all the different forms of mental illness, from simple anxiety in a kindergarten boy, as Sherry knows from her experience. Without diagnosing that young boy with simple anxiety, he turns into a pretty frustrated, angry 5th grader. And I've seen that, having raised 3 children, I've seen this time and time again, and we need to do a better job at identifying these kids, and also the more complicated forms of mental illness. So it just teaches us all sensitivity, how to language it when we see someone having a mental breakdown or a psychotic breakdown. And I think we all need to be more aware of it and more sensitive on how to language it. I know one of the examples they give is we talk about Tom has cancer, but we say Tom is bipolar. So we define someone with their mental illness as that is their whole being rather than just as part of them. Whereas with cancer, it's just part of what someone's trying to live with. So I do encourage you all to look for the mental health first aid training, and I can get the links to where we can all take that. Actually, I have to give credit to Fairfield County Community Foundation and Fiona, and you were on the conference call. I met with you all and mentioned, we had talked about the mental health first aid training, and Fiona said, or somebody said, well, you've got to talk to Dawn Roy. Here's your phone number and here's the flyer. Bingo, and I signed up for it that weekend. So thank you. The other section was, in the gun bill, mental health section, was implementing the assertive community treatment, ACT program, in 3 additional communities, which is Manchester, Middletown, and New Britain. Also, case management and care coordination services to up to 100 people, which is something called Melissa's Project, which is case coordination for those mentally ill in the probate court system to keep them from cycling through the court system and the emergency department. And that's another important initiative. So that's very quickly. I did speak with Dr. Marcy Kane. She is a participant on the task force yesterday just to catch up on what they've done. And she said that there were a couple things that really flew to the top of the list, and Sherry, I'm sure you can speak to this too, and obviously this is your turf. Universal screening practices and little connection between primary health and mental health care providers, that connecting those dots, and also best practices for communities, schools and social service agencies, and then the mental health care and psychological health care within human services within communities. So, should we introduce Judy? Judith, sorry, Dr. Judith is good.
Welcome, Judith.
Thank you.
We saved you a seat and we saved your introduction.
Yes. Yes.
So you can hear.
Because I don't know who I am.
See your face while they hear what great things you've done and what you're involved in. So we are very pleased. You know, we have a full panel now. Judith Myers is the president and CEO of the Children's Fund of Connecticut, a public charitable foundation and a subsidiary, the Child Health and Development Institute of Connecticut. Ms. Myers has been leading the organization's efforts to improve systems for children in Connecticut for over 15 years. A clinical and community psychologist, Ms. Myers currently holds faculty appointments at the University of Connecticut School of Medicine and the Yale University Child Study Center. She has been appointed to the Governor's Early Care and Education Cabinet, the Governor's Blue Ribbon Commission on Mental Health, the Lieutenant Governor's Mental Health Cabinet, Behavioral Health Partnership Oversight Council, and the Connecticut Kids Report CARD Leadership Committee. So I welcome you as part of this panel today, and we've just got it started, so you haven't missed too much. So thank you.
So there are a couple things just in terms of how you think about mental health I wanted to give you as a frame for Connecticut. One is, and you were touching on it, is sometimes, you were talking about the stigma, and sometimes when you actually didn't use that word, but that's what you were talking about the stigma with mental health. And it's interesting, when we talk about mental health, we're usually talking about mental illness. But when we talk about health, we talk about health, and then we talk about illness. But with mental health, we don't usually think about what that means. And in our work we've done, we've developed a framework we use in a lot of our work, which I think is helpful as you're thinking about your workforce or your role in the community, that think about sort of a pyramid. And on the bottom of the pyramid is what's important for what I would call universal or all people. My work's largely with children, or mostly all with children and families, so I keep falling into that, but I know your interests are broader than that. So when we think about mental health, we really are thinking universally about all people. What is good mental health? And how do we promote effective social and emotional development in young children? We talk a lot now about emotional intelligence and social intelligence, and then thinking about sort of the promotion of mental health and the prevention of problems. And that's something that really cuts across everybody. And when you think about the fact that our epidemiology tells us 1 in 5 people will have a diagnosable mental health disorder. And actually in their lifetime it's probably higher, but at any one time it's 1 in 5 people. My guess is that everybody in this room has somebody in their near realm, their family or a friend, who has suffered or experiences some kind of challenge with mental illness. So it's much more pervasive than we sort of acknowledge. So the notion of promoting healthy relationships, good attachments, is very important to think about. And then you get the sort of next level, which is that early identification and early intervention. Because we do know the sooner we can spot it, and we mentioned, that Marcy Kane mentioned, universal screening, which is something we are really very interested in. I know the state is very interested in seeing what we can do about that starting very young. How do we identify those problems very early? Because the sooner we know about them, the earlier we intervene, and the less likely we will develop more serious problems. And then at the top are the people, children and adults, with serious and complex mental health disorders. And that's really about more like 3 to 5% of children, at least, who would fall into that category. And you do need a comprehensive, effective mental health treatment system. So it's important, I think that's just conceptually, to understand the full range of what we're talking about. That's one point I wanted to make. Second is, in the 15 years, Sherry, I hope you would agree, we actually have seen a lot of progress. If I look at where we were 15 years ago, compared to where we are now, as bleak as it feels and as important as it is to address these issues, a lot's happened in 15 years, so, which means a lot more can happen in the next 15 years. I think it's important to keep that in mind. We did, when I first got here, did a report that was a mandated report for the state looking at the delivery and financing of mental health services for children in the state. And we found at that time a great number of children were being served out of state. Excuse me, most of the money was being spent on children in hospitals and in residential settings. Very little money was spent on community services. And we have turned that around. It's not sufficient, and we'll be the first to be able to talk about that. But we have many more effective, what I would call evidence-based practices in the home, in the community, than we ever had before. So that's one area we're seeing a lot of change. And also, when I started here, nobody ever talked about children birth to 5 in terms of mental health. There's this notion of babies on the couch, you know, what are we talking about? Little children can't possibly have mental health concerns. And we got a lot of attention to this from the legislature because we started talking about children being expelled from preschool for their behaviors. And we know the numbers of children being tossed out of kindergarten for behaviors is surprisingly high. And what a way to start your life and your school, you know, your sort of school career. So that really, I think, started to focus attention on that. And now we have an amazing amount of attention to programs and both promoting mental health as well as intervening for that very young population. There was nothing like that 15 years ago. And there was also very little around family advocacy. You know, Connecticut did not have a strong family advocacy movement, and that has changed a lot. And that's another thing to be thinking about, supporting families through family support movement, family advocacy, because they are the most powerful voices for their children. And we have, a lot more of that going on now. So I just want to make those big points. If I have another, just keeping time here, a few more minutes. I wanted to mention Public Act 13178, which was also passed as an aftermath to what happened in Newtown. Senator Dante Bartolomeo and Representative Dinah Urban, who co-chair the Children's Committee, were, I think, the leaders behind that bill. That bill calls for a few things, but the major first section is for a children's mental health plan for Connecticut. So it charges the Department of Children and Families to deliver a plan to the legislature by October 1st. The DCF has contracted with the Child Health and Development Institute to facilitate that. I'm co-chairing the advisory committee of about 36 people who are overseeing the development of that plan. And what's interesting, for the first time, they're asking us to look at all children in the state, not just children, which has been historically true, who are covered under public systems, under Medicaid, or children in the child welfare system, highly vulnerable, no question. Children in the juvenile justice system, very important. But this, and I think again Sandy Hook brings that to our attention, as so many of these other tragedies that keep happening to us, that this, as I said, mental illness happens in a lot of places, and we need to look at all communities, we need to look at all children. And secondly, looking from prevention, looking developmentally from birth up through transition into adulthood, and so thinking developmentally and on a full continuum from prevention through to treatment and transition from childhood into adult services. So that's a very comprehensive plan. We're doing a very extensive information gathering process, and in fact, I don't know if anyone was there, we've had, that's what you can. So we've had 6 public forums to gather information, and the last one was in Stamford the other evening. Had about 50, 60 people there, a fair number spoke. So it's really an opportunity going around the whole state for people to speak up about their experiences, which is what we hear a lot about, the very challenging, sad stories about families who have, in this case again, children who can't get the treatment they need. So we can come back to that. I can talk about some of what we're learning from that information gathering. We've had 13 facilitated discussions with expert panels to gather specific information on specific topics. And people can, we have a website, and anybody can submit written comments or testimony into this process. And if anyone's interested, I can share that website. And you can go there and find out all kinds of information. So there's a lot going on right now around this, and a lot of opportunity to be thinking about everybody's role in that.
And a lot of it has been spurred by Sandy Hook. And the other part of that bill, which I think is interesting, is looking at the incarceration rates and mental illness, which is such a key piece of it.
It really is our mental health system is there.
That's right.
2 other things quickly in that bill, because that reminded me. One is, again, around young children, and it's around training pediatricians and training child care providers around what we're calling infant mental health competencies. We're doing a lot of work around primary care, because that is where many families, how do we build the capacity of primary care providers to be able to screen for, identify, and connect to treatment people with mental health. So that's a whole big area, and child care for us is a second area. So, and then there's a call for a home visiting plan, because we have many, many home visiting programs now in the state, but no integrated system. And again, a point of early intervention for highly vulnerable families when they're having new babies. And how do we promote attachment in those very early years, which is the key to promoting healthy social emotional development. So,
Can I just make one point that Judith's comments made me think of? Judith, we started with the why corporate funders should care. And I think your point about how this behavioral health plan is expanding beyond that publicly served population, Medicaid and DCF involved, to look at the broader, all children. I think one of the facts about this issue that surprises many funders and others is that access to care is actually poorer for people with means than it is for people without means. So as an employer, the reason you should care about this is that for employees, and as Judith pointed out, you certainly have a lot of them, given the statistics. You can count on the fact that you have a lot of employees who are dealing with the mental illness of a loved one, trying to find appropriate care for them. That diverts their productivity in a big way to the extent that they can't find appropriate and affordable community-based care. So I think we can add that to the list of reasons why you should.
Right, private funding,
So
sure,
I
I
would
talked
love-
about this a year ago.
I would love to bring this local now, and I really appreciate you having teed everything up for me. This is wonderful. So this is a real issue, because what we are finding is that there's a lack of understanding often in Hartford about the realities of Lower Fairfield County. And so there has been a lot of progress, mostly for the Medicaid Husky population. And for everyone else, and particularly as we're going more and more into an environment where insurance has high deductibles, what we find coming to our clinic from a lot of companies around is people who have insurance but may have a $5,000 deductible or a $10,000 deductible, and we have to establish a sliding scale fee with them. Forget about once we're even in the world of being able to collect some of their insurance, because we're on insurance panels, but before we can even go to the insurance company, people have to meet their deductible. Well, you know, if you go to the doctor, you know, once in a while, you might be able to pay out of pocket for the full fee. If you're going to come for therapy once a week or twice a week, you have to, you know, our full fee is $175. Almost nobody pays that. So we're setting up a sliding scale fee. The average sliding scale fee is more like $30. We have to subsidize the rest of that, and the person's going to take longer to hit their deductible. So we're in a real catch-22. We have a policy at our agency that we will not turn people away because of their insurance status. So we need a higher level of subsidy. Many publicly supported clinics will only serve the Husky population. And that means that those people can't get in the door. We also have a very large uninsured population down here. So roughly, our population served in my clinic is 60% Husky, 20% uninsured, and 20% with insurance that we can rarely access. So the need for subsidy is higher. And there's no question that being poor is going to be a risk factor and is going to add to a kid's vulnerability. But having means or being middle class doesn't protect you. And I could tell you story after story. We have a family in Darien where the kid is self-cutting constantly. The parents are divorced, living together in a $3 million house that's in foreclosure. We have set a sliding scale fee. We've lowered it to $10. The parents won't pay it. Won't pay $10. The kid walks over to our office to see the therapist. You know, so, and I can tell you story after story like that. And so, you know, we feel like we can't turn people away when there's a serious mental health problem. And we need to figure out how, you know, I have a board of directors that wants to make sure we have a balanced budget. So this is, you know, so we have that conflict between the level of need, the number of people needing services, and I'll speak to the other disparity down here. There are wonderful new programs, and I think the state has done a great job in developing a lot of what we call, you know, kind of step-down services, higher intensity services. We have a few of them that we're very proud of and that we think are great, but if you look at a map of Connecticut and you put pins in every major city in Connecticut for the number of services that are available by size of population, Stamford is bare. Stamford is the third largest city in Connecticut now, and if you look at the allocation of state funds, it is not fair. And so that has, you know, the nonprofit, you know, community, not only in mental health, but in other things, at your door. And that's a reality we all live with. It's a real problem. And so let me kind of talk about from the perspective of our year. We've had a good year in many ways, and we've done a lot of good work. There has been tremendous need. I've been the CEO for 28 years at the Child Guidance Center. We have never had this level of increase of referrals that we've experienced this year. In the first 10 weeks of the school year, there were 3 suicides, 2 in Stamford and 1 in Greenwich. The school people were kind of lambasted in the press, and they became frightened of the responsibility of making decisions about, and they were good people in a lot of the local schools, but they became frightened of the responsibility of making a decision. The kid writes a composition that they're thinking of killing themselves. Do they really mean it? Is it something we have to? So they're calling us. They're calling our emergency mobile program. So our emergency mobile in the first 3 quarters of the year was up 48% over last year. And I went begging to the state. I got a half a year of one additional therapist. So, and I said to them, this is not a trend that's going to stop. It actually started last spring. I have numbers that show it. I go to the state, I beg. So I got a half a person that they're saying they're going to take away at the end of June. And my phone hasn't stopped ringing. And I can't not answer those calls. You have to answer emergency mobile calls.
So 211, emergency mobile.
Yes. So it's a statewide system. The call goes into 211, and then it gets passed through to the local emergency mobile team. It's a great program, and it's one that CHDI was instrumental in recommending. It works. I mean, we get out there. We're out there within 45 minutes. And we're helping resolve problems. We're helping to stabilize kids who might be very high risk.
And you go to schools and
We go to schools, we go to
So
people's
it's
homes.
911 for mental illness.
Right. So that said, there are times when we're looking at a situation where a kid does need a higher level of care, where it's not safe to keep them in the community, and we can't get them into a hospital. We cannot. I mean, I'm not saying never. Sometimes we're able to, but and then the gap of not having those intermediate level of care services with enough availability here is a serious problem. And then whereas to hold the kid in outpatient, which is not sufficient. So I'm going to give you just a couple of case examples because it gives you a flavor for the struggle. So in our emergency mobile program, we're supposed to stabilize crises within 45 days. And in many, many cases, we're successful in doing that. And then we need to decide if there's a need for ongoing support. A lot of those kids can, in fact, move into our outpatient program, but a lot of them need other kinds of services and supports. So a 15-year-old Hispanic female had a history of sexual abuse. She presented with anxiety and depression with psychotic features. The child self-harms by burning herself. She was recently hospitalized for over 2 weeks, but the only available bed was out of state. When she was discharged, it was recommended that she step down from inpatient to a partial hospitalization program. It's like a day treatment, but no such placement was available. She was then referred to ICAPS, which is an intensive in-home program to work with the child and the family 3 weeks ago by the inpatient hospital, but they haven't been able to take her in yet, so we are maintaining her in the crisis program as a bridge. We checked in yesterday, and it was reported that they will not have room for her for at least another 3 weeks. So she's staying at home. She needs a higher level of care. We have had multiple calls to the crisis line, and we're regularly scheduling visits, but even in between those visits, we're getting calls. A 6-year-old, people don't understand, little kids have these problems too, is residing with his maternal grandmother. There's a history of trauma, neglect, and disrupted attachment due to parental neglect, substance abuse, and incarceration of parents. The school recommended a therapeutic outplacement due to disruptive and aggressive behavior and dysregulated mood. There is no therapeutic day school or PHP program that has space for him for the past 2 weeks. Psychiatric hospitals with facilities for children are all full. There are no beds, either inpatient, and there's no PHP program. The child was suspended from school and remains trying to hold with a Band-Aid. And the pressure on my staff, frankly, the liability, our fear that if something happens to one of these kids, what we're gonna feel like, and what it's gonna look like in the newspaper, frankly.
And for families.
And,
I mean, that's
well,
terrifying.
Of course it is. So what I want to say is we had 350 some odd calls in the first 9 months of this year. I would say in 85% of those cases, we did a great job. It was the right call, emergency mobile was right, and we were able to achieve what we wanted. I worry about those other 15%. And it's hard to hold those kids and those families, and as you said, and thank you for the reminder, think about what it is like for those families.
How helpful would it, in listening to you talk about this, how helpful would it be if the community, families, educators in the school system were better educated on what some of the forms of mental illness and behavioral illness look like?
Well, here's the,
For
on
stemming
the
some of these-
one hand, I love the idea, on the other hand, I can't handle the volume of referrals.
Right.
As it is, and even on our outpatient. So we're an enhanced care clinic, we're required to have access within 2 weeks for non-emergency situations. We get people in the door and we do that initial assessment. We then should be getting people into therapy within the next 2 weeks after the initial assessment. I will tell you, we're not doing that. I hope you're not going to tell everybody in the state that. But our volume for regular outpatient is up 28% this year, and we saw over 2,000 kids last year. So this year, we're trying to manage a volume increase of 28%, and we can't do it with the same level of staffing that we have. So what we do is we do those initial, we tell people when they call, we do a screening by phone to make sure it's not an emergency. If it is, it goes over to the crisis program. But then we have to figure out what we're going to do with those families. But at least we have a better picture because we've done a complete assessment and we're triaging off what we're not supposed to have, which is a waiting list.
Right. But it would help, I mean, this speaks to early intervention too. The earlier we
Yes.
intervene, the less we're going to have to.
So now I want to say the positive thing.
Good. 'Cause that's what I was
We
gonna
are
ask.
a child first site. Now, Child First, which Judith can also talk about, is a fabulous program. It identifies very high risk parents, either from the time a mother may be pregnant or, from birth through age 5 or 6. And it provides an intensive service that is a dyadic therapeutic model with care coordination brought into the home. And it focuses on things that make sense to us. A lot of the field has moved to those things that are measurable, which is behavior. There's a lot of stuff that isn't as easily measurable, but you can measure by kind of how kids improve. And the beauty of Child First is it's based on treatment that makes sense. It looks at the importance of building a bond, a reciprocal bond between a mother and a baby. Now that happens naturally in a lot of families. It doesn't happen naturally for families where the mother may have serious impairments of her own, may have been abused or neglected when she was a kid, may be a victim of domestic violence and is traumatized by one thing or another. There are all kinds, may have a mental illness herself. So I'll give you an example. We have a family in Child First that we've been working with for a while, where the mother had been hospitalized several times for suicide attempts. She became pregnant. And we were working with her on an outpatient basis before we had the Child First program, and once we opened Child First, we moved her. By that time, she was 8 months pregnant into the Child First program. The father of the child was interested in being involved, and we began working with the two of them in preparation for the birth of this baby. This mother and this child made such incredible progress, but when the child was first born, the mother, as much as we tried to do some preparation, the reality of a baby is very different from the anticipation of a baby. But the outcome on this case is to look at the improvement in the mother's functioning, the ability of both the mother and the father to really engage with this child and to take pleasure, and you can start to see like reciprocal kind of communications and things. This stuff really, really works. And there's research that talks about the damage to the brain when that doesn't happen. And if things are put in place that early, you can take the highest, I'm amazed at what we have been able to do in that program, and I'm delighted by it. So when we have these resources, it's great. There are a lot of other programs that bring services out to families, and that's a great model. And there could be things about the particular model that are specific and that make it what they call an evidence-based treatment. But some of the common elements are that combination of bringing care coordination services, addressing the concrete needs and stressors for a family, and having good therapeutic theory that backs up how you're working with people. It's not something that anybody can do. You've got to be trained in how to do these treatments. So there's a lot of hope around the things that work. And we love having them, but we don't have enough of them down here. And if you look at not just what services are available, but at what level they're funded, you will see real differences across the state, and that's a problem.
Nancy, Judith, do you have successes you want to?
You had a chance to talk.
Yeah.
Okay. I missed that part. A couple of things I just, picking up on what Sherry said, is the bottleneck is real at the deep end, and we are seeing increased need there, and the issues of access kind of come up again and again. But to pick up on your point, I think we know that if we could sort of take those children and families who are at the kind of middle ground, or even earlier, the high-risk ones, and not and move them out of the mental health system and where they can get services elsewhere, it would sort of free up the child guidance clinics to do what they have to do with those more very serious problems. And the places for those schools are really key. And we do have, I don't know, in Fairfield County about school-based health clinics. But so they're not everywhere they should be, probably in every school, and they need to build, and they're working on it, their capacity to address mental health. They have traditionally not particularly been staffed to address mental health problems, but they're moving in that direction. So ideally, you would have school-based services that would be able to provide training and consultation to the school staff, as well as some early intervention and treatment. I do know Stanford is making a major investment. We're actually partnering with the school district around investing in children's mental health. And the school board just yesterday, I think, voted to put, there's a plan and to put a lot of resources into an assessment of the needs in the school district and developing programs, and we're going to be partnering with the school district on that. So that's fantastic, and maybe if you don't know about that, you probably want to talk to the school folks to hear more about that. The other is the state just funded, and it's about to roll out a program called Access Mental Health. And do you know about that? Okay, so that, and that's, it's providing a consultation service for psychiatry to pediatrics. And so they've, Value Options, which is the service the Administrative Services Organization for Husky Mental Health Services, got the contract from the Department of Children and Families. They've selected 3 hubs, and the Yale Child Study Center is one of them that will be serving this area. And that's going to be a telephone access line for pediatrics or primary care to call and get assistance in managing a mental health situation, whether it's medication or referral for treatment. So that's about to roll out. It's supposed to get started in June. So again, another support within pediatrics to help enhance the capacity within the medical care system to help with some of these medication problems and treatment problems. So there's things beginning to happen to sort of build out other systems to help partner in what we call a system of care. It takes everybody to be familiar with these problems and to be equipped at their level, at the appropriate level of expertise to be able to intervene. So,
And just to mention that is part of the reason that came about, it was part of the mental health part of the Gun bill last year, is there's a shortage of psychiatrists in the state of Connecticut. Because they don't want to stay here, they don't want to train here. And this increases the access, and it does close that gap a little. Nancy, make a comment, and then open it up to questions.
Yeah, just, I wanted to amplify your comment about school-based health centers, because I don't think that can be overstated, the important role that they're having in addressing this issue. In Norwalk, the majority of the school-based health center visits are actually mental health related, behavioral health related, and they've added school-based health center services in their middle schools, and it's only behavioral health related services that they've added there because it seems such an incredible need for it. And then the other thing I just, as something that's happening and having I think, a very positive impact is that our police departments are actually getting some crisis intervention training around mental health that is really dramatically changing the way they respond to calls involving somebody in a mental health crisis. And I got to hear a police officer in Fairfield talk about how much that had changed their practice and how much it had improved the safety both for police officers who are responding and for family members and for the person who is in crisis. They would have, in the old days, they'd go in a typical sort of law enforcement way and say, what's going on here, John, and cuff them and say, you can come with me willingly, or I can make you come, and then they'd be, processed through the justice system, and it didn't get people to the right kind of care, and it often escalated the crisis, and it was dangerous and ineffective. Now they go in, and with the knowledge that they have, they can, and they even keep some data, so they know, if they've been called to a home before, they may know that somebody suffers from bipolar disorder, and they'll say, are you off your medication? How long have you been off? What do you think triggered this? Who have you spoken to your doctor? Just a totally different approach. It de-escalates and increases safety and increases referral to appropriate care. And so I think that's, another improvement that's helping to build out this system of care that you referred to.
Yeah, and I just want to add to that. I mean, we've had, I think it's over 15 years now, a partnership with the Stanford Police Department that's based on a model that came out of New Haven. It's the Community Policing Partnership with the Child Guidance Clinic. And so we do training with the police on mental health things regularly. And they also call through 211 when they have a situation where they want us to be deployed with them to a home. It's everything from, we got a call that, a husband woke up, found his wife dead in the morning in bed, and there are 3 kids at home. And they call us out to come and work with the father on how to talk to the kids about what happened. We got called out when a man hung himself at home, and it was his 6-year-old who found him hanging. So those kinds of, they're very good at calling around things like that. They are less likely so far to call about a kid who's acting out. They still will tend to treat that more as something that they have to manage. But they're very good at, really seeing now the things that are impacting kids and that need some mental health intervention.
Bobby's been trying to ask a question for about 20 minutes.
Okay, we're going to stop talking now.
Okay, an excellent point was made a little while ago that it's not so much the identification right now, it's the servicing and it's the capacity. And we're not going to see it from the state and from the federal government, and we need to figure out how to present this to our consumer audience and our corporate audience, where philanthropy at the individual to lower levels are directed to help this area. Everyone here knows I'm on the board of Catholic Charities. We have over 25 programs. Just recently we had our annual fundraiser here for the new Covenant House, our soup kitchen. These are the type of projects that it's easier to fundraise for and to gather support, that people feel good about it. But mental health, it's still a little bit on the side. Our behavioral health area in Danbury, Bridgeport, and Norwalk serve the lower-end community. We lose $65 per visit and lost over $300,000 last year from that. And we have a
State
very,
funding?
pardon?
When you said you
No,
lost
no.
300,000.
We lost, for every patient we serve,
Got
it costs us, we lose $65. So our bottom line was a negative $300,000 as a result of that. But to go fundraise for it,
Yeah,
it's
very
it's
tough.
much more difficult. We need to figure out, as community leadership, how can we fundraise for this? The other thing that we've been discussing is the prison populations. So much of that is a proxy for what we used to have in our mental hospitals. And there's a group of people who have come together in our, on a nationwide basis, but it's being spearheaded from people here in Fairfield County. And there's a major book coming out shortly on prison reform and starting to deal with this. And so we need to figure out how to address it, how to put more money in the cash register to service. We can continue on doing a better job in identifying, but if we identify more people, but we don't have the ability to serve, we're going to give them poor care, if any care.
Yeah, you know, I often think of it, there's some movement building that needs to happen, I think, around mental illness. I think of it, there's some parallels, I think, to HIV/AIDS and to breast cancer, as I think you said, Terry. You know, there was a time when the stigma around HIV/AIDS was keeping people from talking about it, but there were some champions from every sector, from the corporate sector and from the private individual sector and from philanthropy, that got behind breaking down those barriers, forcing the issue, advocating for change. It drove public funding, but it also, that public funding was wrapped around by a lot of private funding. And the same thing has happened with breast cancer. We haven't had that movement with mental illness yet. And I think it's, well, I think it's beginning to build. I really do think it's beginning to build. But it doesn't have that momentum quite yet, hasn't reached the tipping point quite yet.
And yet it's so much more prevalent.
That was actually going to be one of my questions, like, are there programs out there that you're aware of that are really helping to break through the stigma? And just happenstance, I was driving by the library the other day, and there were students and people out with signs about mentally ill parents that were their heroes, and my kids were with me in the car, and it got us talking about what mental illness is, or mental health is, and so I feel like that broke through some of the stigma, but I'm curious, that there are cultural issues too. We have a large immigrant population. They come from countries that have no value or appreciation for mental health. What's helping break through those barriers?
I just want to mention again the mental health first aid course, because that is one of the primary reasons to take the mental health first aid course, is to understand more about mental illness, so that we can all understand it. And we're trying to do it in every community.
That was very interesting. I actually boxed that in here, this mental health first aid. It'd be interesting to see how we can deliver that more efficiently, and maybe we can help get that out there in the corporate community, in all of our community organizations. That might be something interesting.
We can touch base, because I've helped organize a couple in the capital as well.
Does the Red Cross have a component of that in their normal first aid course? Like, why is it separate?
It's separate because it's complex. It's a lot of information.
How long is that?
It's an 8-hour training, and some of the local trainer, I think, actually builds it into a 10-hour program.
Well, it started off actually as 12, and they
Yeah.
reduced it to 8. I don't think the 8 is quite as effective.
Yeah.
But
And it's separate for adults and children?
yes,
Yeah.
they
For
now
separate
have
courses.
Well, yeah, for people serving children.
That's right.
Yeah.
So I want to go back to the family engagement question that came up in here in this conversation, because it's, you know, you're dealing with a very different situation when you have a parent who is sophisticated, understands what therapy is, and is self-motivated to get help for their kid and believes in it. We are often in clinic practice getting people referred to us who are being coerced into coming.
Okay.
So, you know, the school is saying, we're suspending your kid until you get them senior child guidance, we're not letting them back in. Or DCF, you know, is called and, you know, we're gonna remove your kid if you don't go get help. And you know, or court involved. So a lot of the families are being pushed into coming. They don't, the concept of talking to strangers about personal things doesn't come naturally. A lot of our effort has to go into trying to engage people and to try and make them comfortable and to try and talk about these issues. And then, you know, and then you have the issues of you have to pay a sliding scale fee and, you know, all those problems that can be real barriers for people. We also have that bumping up against capacity. So what we struggle with a lot is if we have people waiting to get help and you have some families who are not showing up for their appointments, do you get, you know, expel them and get somebody in who will use the time? Or do you try to invest the time in getting the family to understand and understanding why they're reluctant to come? And we would rather do that, but we're often, you know, saying, well, you know, can we afford to have a therapist sitting there with an empty prime time hour, after school hour? These are some real issues in clinic practice. And I think we're doing a good job of trying to meet the balance on that. But that's why some of these in-home programs are so important, because it brings the service to families, and families feel heard, they feel taken care of, they feel it makes a big difference. And then after you've done a course of the intensive in-home, you're then more able sometimes to get them to come to once a week, you know, therapy. But it's a complex system.
I've got a couple of questions. Are you working at all with, I know Dr. Rabinovitz in Bridgeport is really focused on social and emotional health, and is that something that you're working with her on as far as trying to roll that out to the Bridgeport system? Because it is something that she's very concerned about, has placed some real emphasis on, and is interested in sort of social emotional development for children. The second question I have is, and you can answer them in order, or is there a disproportionate challenge in diagnosing particularly Latino and African American males in terms of categorizing their behavior properly as, are they immediately labeled, is there just labeled as just
Yes.
troublemakers, as opposed to understanding that there may be some kind of behavioral or mental health challenge? And are you seeing evidence of that, or any level of awareness of trying to address it?
I'm going to take the second question.
Yeah, I could take the second one, please.
The answer is yes. It is disproportionate. We do know more children, minority children in the criminal justice system, where they are addressing some of the mental health problems. But there is a program that is now trying to spread called the School-Based Diversion Initiative, where we go into schools with high arrest rates and train the teachers, train the police, work with community resources, so that they, again, understand the problem, know to call EM, the emergency mobile, rather than call the police, and to connect the schools to community resources. And we are seeing, we're evaluating that and seeing some really nice results as a, you know, again, spread and scale. We have lots of wonderful programs and models in the state. We have a very hard time taking them to scale and making sure they're everywhere. So that's a real challenge. So that's the answer, one answer to the second question.
And I'll do a quick one on Dr. Rabinovitz. I would love to get contact information from you. It sounds very interesting.
And are you using expressive therapies at all? I'm a trustee at Leslie University, and their fastest growing programs at both the undergraduate and at the graduate level are expressive therapies, and they're really using expressive therapies to work with adults and children on the spectrum of any kind of mental challenges. They use art therapy, drama therapy, music therapy, and they're finding that it's really quite effective in dealing with a whole host of, you know, from learning challenges and disabilities to mental illness or bipolar disorder, or a number of things that they're finding it's effective.
Yeah.
And I just wondered if you're using, if you see that happening here.
We use a lot of art therapy. at Child Guidance. We have an art therapist who's the director of our multidimensional family therapy program, which is an intensive in-home program, and use it a great deal. And also play therapy with little kids using play materials, working in metaphor is how I think the most effective way to work with little kids. And when you're working in dyadic therapy with a parent and a young child, being able to use materials and help the parent to play with the child and understand the child's play is a very important intervention.
Is this a new type therapy up at Leslie Pell?
No, it's actually, the program has been in place for many years. It's just, of all of the graduate and undergraduate programs, it's the one that's growing the fastest.
Interesting,
As opposed to some departments where you don't see as much of an enrollment, that's one that,
because it's been successful.
yeah.
Well, there's something else called Emdr, eye movement rapid desensitization, which I think is used more in trauma situations, but that's also gaining more popularity, my understanding is. You had a question?
Yeah, so for those I don't know in the room, I'm Kim Morgan with United Way Western Connecticut, but speaking from a personal perspective, I want to thank you because I'm an adoptive parent for DCF, and 3 girls, attachment.
Yes.
I have 2 girls who came to us at a much older age, 5, 3, 5, in and out of shelters, drug abuse, all sorts of situations. Don't have any issues because their mothers loved them and attached to them. I have a child that I got at 15 months, reactive attachment disorder, sensory integration, ADHD, obsessive compulsive, mood disorder, there's a couple others in there. Just a complete, and nobody told me, I'm an intelligent woman, this 13 years ago, but until I got to the public school system, even though I had a DCF worker, even though I had a background in adult mental health for 15 years, nobody said, there's something wrong with this. I knew there was something wrong, but the attachment and the early intervention and the brain science that's around that right now is just astounding. We had to find it out for ourselves. And the families of means, absolutely true. It's very difficult if you don't have the resources to pay those deductibles, etc., because they're all out of network, they don't take insurance. There's a lot of obstacles for families who, you find the family with the mentally ill mother, you identify them pretty quickly. They're at the hospital, there's interventions. It's the families that have children that appear to have it together that really, sometimes those children are not getting the services that they need. So thank you for talking about that.
I want to say something that might seem incredibly obvious, but I think as a society, we don't completely recognize this in the way we talk about mental illness and respond to mental illness, and I'm not talking about our providers, I'm just talking as a society. Our brain is an organ. It is the most complicated organ in our body. So why is it so hard for us to wrap our arms around the fact that our brain can be ill?
And that's to the heart of it.
Yeah.
I'm just thinking again about corporate and your roles and your influence. I have as part of this information gathering and special conversations we're having this afternoon, we're going to the Department of Insurance and meeting with representatives from the 5 larger insurance companies in Connecticut. And when we go around and listen to both providers and families, the issue for the families who are not covered in the public sector, that it is that one of the biggest problems we have in terms of accessing care is the coverage under commercial insurance, or the lack of coverage, or it's self-insured. Some of you may have, you may have your own self-insurance. And it's a hard nut to crack because policy-wise, we're limited in what we can do. So we have to engage them, and there's certainly an economic argument that can be made earlier. But I think we need advocacy. We need from the corporate community who are purchasing, who are the major purchasers, to be partnering around the importance of, we have parity laws. So everyone says, we have parity, which is equality supposedly between coverage for mental health and health. In its implementation, it's not taking care of the problem.
Right, well, and again, it's the high deductibles. I mean, we've had some success in getting some of our, services covered once people have passed that deductible.
But the deductibles are very high.
Deductibles are
They're prohibitive.
They are prohibitive. A couple more questions, and then I think we need to wrap it up. But I know a number of us could probably stay and answer any other questions.
I just think we have to be careful when we go down the insurance route because this is whole can of worms that we're uncovering. We're one of the worst states in the nation in terms of requirements to be covered. I mean, we have so many requirements. No wonder our insurance is so expensive. Insurance is not a proxy for what we should be doing with our household budget. And that's also resulted in such a high deductible. And we're trying to balance the overall cost. So we almost have to go, as a completely separate issue, study the subject of insurance and what it's meant to be and do.
So can I make one comment about something that I think the corporate community can do that isn't about money? I would love to see some of the companies who have lobbyists get their lobbyists involved on a pro bono basis advocating on some of these issues. Because I think these are issues that matter in our community. The corporate community in this area has been very generous in many, many ways, and is partnering with the nonprofit sector. And I think, frankly, it would be very nice for your reputations up in Hartford if your people were coming in and talking about human issues, not only the self-interest issues of your company and, tax breaks and those kinds of things that get put all over the newspapers. So many of the companies have been so involved with the nonprofit sector and have had partnerships, and people are always asking, well, are there ways that we can have volunteers come in and do things at your agency? This is something that, on a voluntary basis, when we go up, it's all of those providers, it's all self-interest, they're just asking for money. If they started hearing from some of the corporate people about, we care about mental health, we want to see Lower Fairfield County get its fair share of services, I think that this is a real
I
opportunity.
think that's a great idea. A quick wrap up from three of you, thoughts to leave everyone with?
I just, I sometimes am a half empty person, I'm sometimes a half full. I am very excited at how much better we have gotten at providing mental health services. We know so much more than we did when I entered the field, and we're better at doing it. And the state has, in fact, improved in, adding to that continuum of care. But every day when I look at the kids who we are not helping adequately because we can't get them all in the door as quickly as we would like, I worry about what the consequence is. Please remember that a kid's ability to learn is so tied to how they're doing emotionally and behaviorally. And if we can make that link better, and we can work more effectively with the schools and get the support for doing that work, it would really bring us to the next level.
Thank you, Sherry. Nancy?
I'll try to stay on the glasses half full and just amplify your call for advocacy. I think there's a real opportunity right now for advocacy when we talk about building that movement and getting to the tipping point that I think we need to get to. And we've talked a lot about what's happening on the state level, but there's actually some really important stuff happening on the federal level that you could help to move forward as well. This spring, the most comprehensive mental health legislation ever has been proposed in the House, and really is going to need some advocacy to move forward. So there's two bills. The Helping Families in Mental Health Crisis Act, H.R. 317, and the Strengthening Mental Health in Our Communities Act, H.R. 4574. So there is conversation happening. There's some really comprehensive legislation. It hasn't, made it through both houses yet, but there is great bipartisan support for this kind of legislation, and I think if they hear from constituencies, it has a chance of success.
Those numbers again?
H.R. 317 and H.R. 4574.
Thank you very much.
Highlight just
Yes.
before you.
Yeah, this is our, thank you, Jackie. This is the Healthy Minds, Healthy Communities report was published by the foundation in time for the beginning of Mental Health Month, which was May. We worked collaboratively with the Southwest Regional Mental Health Board and NAMI, National Alliance on Mental Illness. They convened community conversations across 15 different community conversations across coastal Fairfield County, reaching out to some special groups, particularly affected by mental illness, and it was a multi-stage conversation, and this report shares some of the findings from those conversations. And these are real stories from real people about the challenges that they're facing in meeting their mental health needs.
Thank you very much. Judith?
The only thing I guess I want to end with is to say that by your being here this morning, you're clearly already people who are aware of this, interested and invested in either learning more or committed in your lives to this issue. So you're not the ones who need to necessarily hear the message, but you're in a key position to take it back. And I think one of the biggest challenges is to normalize this, to normalize the conversation about mental health, about people with mental illness, and thinking about how you can do that in your workplace is a great place to start, because that's the most normalizing place, and thinking about the workforce where you are, and how do you open up, create the conversation, create the opportunities, think about the stresses on the families, and make that sort of as much part of the conversation as your other wellness programs that I think many corporate communities have. So thank you for being ambassadors to this issue.
And I would just make an offer that we will send people out to your companies. If you want speakers to come out and speak on any topic having to do with child development, mental health issues, I have experts at Child Guidance, and we love doing community presentations.
Thank you to Fairfield County Community Foundation, Juanita and Carol, for organizing this, and Nancy, certainly your involvement. And thank you all for being here.
Thank you.